right. So my name is Jill. I'm one of the transplant pharmacists here. We have a whole group of us transplant pharmacists. I put everyone else's names up here just as those of you who work frequently with our transplant patients know that oftentimes we cross-cover for one another or we have different weekend coverage. So just so that you can familiarize yourself with our names. And today I'm going to kind of do some review on pharmacotherapy in transplant patients. So induction immunosuppression, maintenance immunosuppression, prophylaxis medications that we give, and then also kind of very briefly start to touch on some of the medications we use in rejection therapies. So just kind of really quickly, I put some slides together just to review some of the cell lines we're talking about, because I think it helps make a lot more sense of where the therapies are targeted and kind of the purpose of the therapies. So obviously the immune system kind of broken into two branches, the innate and the adaptive immune system. Most of our anti-rejection drugs and our medications the transplant patients are on are targeting various cells of the adaptive immune system. And so there are two different types of rejection that we concern ourselves with. So there's humoral, which is B cell mediated. So those B cells become a target. From that lineage, then we also develop plasma cells. Plasma cells, you'll later see, are also a target for some of our drugs. And then there's cellular mediated rejection. And this is really driven by T cells. So the T cell response is one of the things that we target with our maintenance immunosuppression, induction immunosuppression, and our rejection. So when we just kind of look at the components of the immune system, so the major histocompatibility complex, or MHC, this is what helps us distinguish self from non-self. So in humans, we have the human leukocyte antigen, or what we call as HLA. These are expressed on surface of antigen-presenting cells. And the antigen-presenting cells that these can be expressed on could be B cells, macrophages, dendritic cells. And their job is really to display the HLA to the host T cells, which then will either cause or T cell activation. So when we look at our T lymphocytes, so the cellular mediated rejection, there's kind of two different types that we look at, the CD4 or T helper cells. These recognize our MHC class 2. So our class 2 HLAs, it helps to stimulate B and T cells. And then we also have our cytotoxic or CD8 T cells, and these recognize MHC class 1 and help to kill infected cells. And then we kind of already briefly spoke about the B lymphocytes that really drive humoral or antibody-mediated rejection. This is a general overview of T cell replication, and I put it up here because these three different signals that you can see in red are the targets of most of our maintenance immunosuppression. So for those of you more visual, there's that. For those of you who kind of prefer things written out. So signal 1, I'm going to flip back and forth between the two slides. So signal 1, you can see this is where an antigen-presenting cell presents the HLA antigen to the T cell through that T cell receptor and CD3 complex. The downstream effect of that signal 1 is that you begin to activate the calcineurin pathway, and then from the calcineurin pathway, from the nucleus of the cell, you'll begin to generate interleukin-2 or IL-2. Signal 2 is happening, then this is the co-stimulation signal. So signal 2 is when you have binding of CD80 and 86 on the antigen-presenting cell to CD28 on the T cell. This signal 2 is vital for the T cell to continue to replicate. We have one very specific medication that targets this signal. And then signal 3, sorry, going back here. So signal 3, this signal covers kind of several parts of the T cell replication, but really starts with the binding of interleukin-2 all the way down through our mTOR pathway and then into our cell cycle. So through these three signals, you'll begin to have T cell activation and replication and proliferation, really. And so if that's allowed to continue to occur in our transplant patients, this is what can lead to rejection, which can then lead to destruction of the graft. So we target that T cell replication at several different steps with our maintenance immunosuppression, which we'll talk about in more detail. So then the goal of immunosuppression is really to help promote the acceptance of the donor graft, prolong patient and graft survival, and to prevent acute rejection while minimizing the risk of infection and toxicity. So it's kind of this balance between the two in many of our patients. And that balance will change kind of throughout the duration of the transplant patient's life. So different factors that we look at, so there's different donor factors that you may want to consider, the age of the donor, the organ quality. For obviously not heart transplant, but when we're looking at kidney transplant, living versus deceased donor, HLA matching. When we're looking at recipient factors, age, ethnicity, a patient's PRA, so those patients who are more highly sensitized with a higher PRA, we may take a different approach to their immunosuppression, comorbidities, and then any underlying infection and or malignancy history will all impact what we do with immunosuppression. So breaking it down into induction versus maintenance. So induction is this short-term therapy. It's used at the very beginning of, at the time of transplant. And its purpose is really to lower the incidence of rejection. Another kind of purpose of it is it allows us to delay the start of maintenance therapies, depending again on the patient's circumstances and if that's something that we are wanting to do. And then the use really depends on several factors. But depends on the immunologic risk of a patient. So the higher that risk that patient is, say the higher their PRA is, we may consider a different induction therapy than those patients with a 0% or low PRA. Induction therapies will also vary across the different organ types. And then there is always the option of no induction. No induction is what we primarily use here in our heart transplant program. We do give large dose steroids, which you could argue is a sense of induction. It's just not with your more classical induction agents. And then maintenance therapy is obviously the long-term immunosuppression and is kind of lifelong for the duration of that patient and graft. So reviewing first our induction agents. So we have two different kinds, depleting and non-depleting. Our non-depleting agent is basiliximab, and then we have two depleting agents, alemtuzumab and rabbit anti-thymocyte globulin. For the sake of kind of focusing more on what we would potentially do in our heart transplant patients, it would be using rabbit anti-thymocyte globulin or the depleting therapy if we were to give a depleting therapy. More commonly, though, you would probably see basiliximab if we were to give induction, and then kind of, as I mentioned earlier, most common would be that patients would receive neither, and they would receive just the bolus dose steroids. When we're talking about kind of where the induction agents are working, so the non-depleting therapy, the basiliximab, its target is actually here at the receptor on the T cell, the CD25 receptor, which is where interleukin-2 binds to help with T cell activation and replication. So basiliximab is a chimeric monoclonal antibody. Again, it binds to that CD25. It's given in 2 doses, so post-op day 0 and post-op day 4. Just some logistic pieces is it does not require pre-medications. It can be given peripherally if that's the only access a patient has, and has relatively short infusion times. We'll talk a little bit more about the comparison between the two here in a moment. Compare that to rabbit anti-thymocyte globulin. So this is a polyclonal antibody product. It's targeted against various T cell markers and helps to induce T cell depletion. So the half-life of this drug is roughly 30 days, with lymphocyte depletion persisting for months. Usually it's around 3 months that lymphocyte depletion will persist after this drug. Given to our higher immunological risk patients for induction, or you may more commonly see it for the use in acute rejection. When we look at dosing of this, so it's 1.5 mg per kg. And that can be given anywhere from 3 to 5 doses, sometimes even more than 5 doses in certain instances of acute rejection. We monitor and adjust dose based on white blood cell count and platelet count. There are various cutoffs as to when we give full dose versus half dose versus when we hold completely. It's administered over 4 to 6 hours, and we typically do central line administration. Up until this year, actually, Houston Methodist only did central line administration, Thymoglobulin, and we are shifting a little bit for certain patients to get it peripherally instead, but first doses and induction doses will always be given via central line or via a PIC if a patient already has a PIC. Thymo does require pre-medications just for the risk of infusion-related reactions. So when we're looking at the kind of side effects of either of these agents that we would worry about, really for the most part, Simulect has much lower incidences of all side effects. I think you could argue maybe that there should be a plus sign there next to infections under basiliximab, as we do sometimes see more infections in our patients who have received Simulect versus those that have not. But everything much more persistent with those patients who get Thymo. So infections, there's infusion-related reactions. There can be both acute and persistent leukopenias in patients who receive Thymo. Historically, across all organ types, patients who receive anti-thymocyte globulin have had a higher risk of post-transplant malignancies. And then serum sickness can occur, which is a delayed response when patients develop antibodies to the thymoglobulin, and then thrombocytopenia. So again, all of those much more common with Thymo than they are with Simulect. For the most part, Simulect is relatively well tolerated. And then I just wanted to pull this up quickly just to show y'all, those of you who I've already worked with before, when patients come out of the OR, one of the biggest things that sometimes gets delayed or gets missed is putting in the post-transplant steroid taper. And so I show you there's a couple of different order sets, right? There's the post-op OR to ICU, and then the pre-op admission. So that pre-op admission order set typically put in by the coordinators. This is put in, on call to the OR for transplant, and then the OR to ICU order set is where you can find the post-transplant. So this is the pre-op order set. If the decision was made for a patient to be getting basiliximab, sorry, ignore my typo there, or if they need Simulect, you can see it's already built into that pre-op order set, and it just simply has to be a click to add on in addition to the methylprednisolone that's already given. And then the second dose of Simulect I would take care of kind of on post-op day 4. For the OR to ICU, in case you're ever covering when a patient comes out of the OR, both of these orders, the post-op antibiotics and the IV steroids, are auto-selected when you choose that order set. So it automatically will put in the whole steroid taper. So I just throw that in there for information. People often ask about it. So then shifting to maintenance immunosuppression. So we're going to talk through several different classes here: our calcineurin inhibitors, our antimetabolites, the target of rapamycin inhibitors or the mTOR inhibitors, and then corticosteroids. So calcineurin inhibitors, we have cyclosporin and tacrolimus. We have much fewer patients who are on cyclosporin anymore. Often it's patients who are remote from time of transplant and or had some sort of intolerance to tacrolimus. We do not use the Sandimmune products, so you'll more likely see Neural or Gengraph. And then I'll talk through the various tacrolimus products now that we have. So we have generic tacrolimus, obviously, which is generic for the brand name Prograf. That's our immediate release product. And then there are 2 extended release products, both brand only, Astigraph XL and Envarsus XR. So again, these calcineurin inhibitors are working on the calcineurin pathway, which is one of the downstream effects of that signal 1, the binding of the antigen-presenting cell to the T cell. So both cyclosporin and tacrolimus, kind of their effect on inhibiting that calcineurin pathway is to prevent the production of IL-2 from the nucleus of the cell. So to prevent kind of one of those first steps in how the T cell is activated to replicate. Both drugs are extensively metabolized through the CYP3A4 system and also through P-glycoprotein, which means they're prone to a lot of drug interactions. Kind of focusing first on the left side, so cyclosporin, like I said, Sandimmune, we don't use it. It has poor erratic absorption, which is why the modified product, cyclosporin modified, was developed. The brand name of that is Neural. It essentially ensures better absorption and more predictable levels. It comes as a capsule, an oral solution, or an IV. And then tacrolimus, again, there's the brand name Prograf. There are numerous generics now of that brand name, immediate release Prograf. Then there are 2 branded products, the extended release Astrograf XL and XR. And then I just kind of put, for completeness sake, the different formulations that they come. When we look at kind of focusing on the tacrolimus still, so the immediate release products, for the most part, patients are on twice daily. We have some patients, though, that you will see on just, once daily 0.5 milligrams in the morning of the immediate release product, just based on how they metabolize that drug. But most frequently, what you'll see is twice daily with that. The extended release products then are given once daily every 24 hours. And then we really adjust doses and target to various troughs. So those are either based on a 12-hour trough or a 24-hour trough. So if a patient's on the immediate release, obviously they're on twice a day. We have a 12-hour trough in the morning. If they're on the extended release products, the Envarsus or the Astrograf XR, we're looking for a 24-hour trough, meaning that patients ideally take their doses in the morning and that we then are checking trough levels in the morning. Depending on where a patient is post-transplant, their goal could be anywhere from 5 to 15. It'll, again, just vary based on different recipient factors. I put on here some conversions. So most importantly is probably going from oral to sublingual, since that's something we frequently do, especially in some of our ICU patients or patients who aren't able to swallow the capsules. And so that's essentially a 2-to-1 PO to sublingual. So if a patient is on 5 milligrams twice daily oral, that would be 2.5 milligrams twice daily sublingual. IV to PO, we look at as roughly a 1-to-4 IV to PO. For the most part, though, I find that actually even overestimates the patient's need. We, at all costs, really try and avoid using IV tacrolimus for several reasons. Logistically, more side effects. So as much as we can, we go to the sublingual route for those patients who can't either swallow capsules or do not have enteric access for us to give suspension. And then the cyclosporin is over there on the left side. But again, we just don't see that as much, so putting more focus on the tacrolimus. But it is twice daily, 12-hour levels. So I think a common question that kind of comes up is all of the conversion amongst the tacrolimus products. So I put this slide in here just as kind of a guidance. So when patients are switching from immediate release to extended release products, for the immediate release Prograf to Astrograf XL, this is a 1-to-1 total daily dose conversion. So if a patient's on 2 twice a day of immediate release Prograf, that would be 4 milligrams of Astrograf XL. And then obviously that would be flipped if a patient were to, be on Astrograf at home and they come in and they need to be switched to immediate release product. For the Envarsus, it's roughly a 1 to 0.8 conversion, so approximately about a 20% dose reduction. African American patients do typically require higher doses of Envarsus XR. Just something to keep in mind. And then again, there I have kind of an example of how you would need to switch. I think that becomes most important if a patient is on one of the extended release products at home, they come in and let's say they're septic and they get intubated and go to the ICU, they won't be able to receive either of those extended release products. And so they would need to be switched to immediate release and then maybe even switch to suspension or sublingual administration. I have the sublingual administration there. We kind of already talked through that. I think another big important part of that is after the dose is administered under the tongue, patients are encouraged not to eat or drink anything. If the patient is intubated, we encourage no suctioning or oral care about 15 to 30 minutes after the dose, just to ensure full and complete absorption. And then again, avoiding the IV tacrolimus. If for some reason you do feel a patient needs IV tacrolimus and you're covering overnight or you're covering on a weekend or something, my recommendation is just to always consult pharmacy. Dose adjustments in the setting of a strong 3A4 inhibitor, so especially voriconazole, which those of you who have covered our transplant patients know many are on, and our general approach is to reduce the dose by 50% when voriconazole is initiated. So then also the flip is true. If we were to all of a sudden stop voriconazole, in general, we usually then would double the dose. Now the other azoles, such as fluconazole or itraconazole, we don't always see the same extent of 3A4 inhibition. Voriconazole is definitely the most potent, but those drugs do usually require some dose adjustment of the patient's CNI. And we're looking at side effects comparing cyclosporin to tacrolimus. So they share a lot of similar side effects. Some of the hypertension, hyperlipidemia are much higher with cyclosporin than we see in more modern times with the tacrolimus. However, tacrolimus is associated with much higher rates of new onset diabetes. As far as electrolyte changes, similar rates of hyperkalemia. There is more hypomagnesemia associated with tacrolimus than with cyclosporin. Both are nephrotoxic, both acutely and chronically can cause nephrotoxicity. Neurotoxicity. So neurotoxicity can range in various ways of how that shows up for patients. So it may be as simple as a headache or a hand tremor. Patients, it may be more significant even as far as seizures, comatose-like state. All of that has been much more associated with tacrolimus than it has with cyclosporin. So in some of our patients where that has become an issue, switching to cyclosporin is actually an option. Tacrolimus is associated with alopecia, whereas cyclosporin has hirsutism and gingival hyperplasia. So just for you to kind of see the various side effects that can occur here. Talking about the neurotoxicity specifically, so kind of when we look back at the various products, right, the immediate release versus the extended release. One of the proposed kind of mechanisms behind that neurotoxicity is that it may be related to the peak of a patient's drug levels. So most commonly we monitor troughs as a way to look at really efficacy and also safety. But it's thought that the peak of the drug may be what's inciting some of the neurotoxicities for patients, and that various patients, just depending on how they absorb the drug, may have higher peak effects. And so the thought is switching patients over to extended release products where you get much more, once you're at steady state, your levels are much more stable and you don't get those high peaks and low troughs. And then patients are able to kind of have a more steady exposure to drug and potentially maybe minimize some of the neurotoxicity. Some even argue maybe minimize some of the acute nephrotoxicity that can happen with tacrolimus. So those are reasons that we have considered switching to the extended release products before. Switching then to the antimetabolites. So we have azathioprine and then our mycophenolate products. So these are primarily working here in the cell cycle and nucleotide synthesis. Have here the different mechanisms of action, but really to inhibit DNA and RNA synthesis. Important thing to know about mycophenolate mofetil is it does undergo enterohepatic recycling. Azathioprine, we typically don't have very many patients on anymore. Again, these are more remote patients if they are still on therapy. So focusing a lot more on the mycophenolate. So it comes as CellCept, is the brand name, capsules, tablets, oral suspension, IV, typically dosed anywhere from 2 to 3 grams per day in divided doses. So our kind of standard dose in our heart transplant patients is 1,500 milligrams twice a day. The other product option that we have here is Myfortic, which is a delayed release mycophenolate acid formulation. And this was really developed to help reduce GI distress that can happen from the drug. So it comes in various tablet strengths. And when you're looking at kind of if you wanted to convert a patient from CellCept to mycophenolate, 250 milligrams of CellCep is equivalent to 180 of the mycophenolic acid of Myfortic. The most common side effect, hands down, that we see with CellCep or Myfortic tends to be GI-related, diarrhea, nausea, gastritis. For some patients, switching to Myfortic helps. Some patients, it may not. We also see myelosuppression with these drugs, so drop in white count, drop in neutrophils, drop in platelets. And then with Imuran, primarily myelosuppression. You can also see alopecia associated with Imuran. Switching then to our mTOR inhibitors, so we have two, sirolimus and everolimus. Sirolimus is the brand name Rapamune, and then everolimus is the brand name Zortris. Everolimus is also available under the brand name Afinitor, which is the product used for oncological indications, but for solid organ transplant, we utilize Zortris. So again, these drugs are working here as part of the signal 3, really that mTOR pathway. So these drugs here, their role is to, by inhibiting the mTOR, they prevent the phosphorylation of the kinases that are involved in cell cycle progression. So again, to just halt that T cell replication from occurring. Sirolimus, the important thing to know about it is it has a very long half-life, roughly 60 hours. Everolimus also has a longer half-life, it's 30 hours, but it's not nearly to the extent of sirolimus. And then both of these drugs do undergo 3A4 metabolism, so similar to our calcineurin inhibitors, they're prone to drug interactions. Both products are available as tablets. The Rapamune is available as a solution. I bring that up mostly because for patients who are on mTOR inhibitors, again, go to the ICU, get intubated, don't have an NG tube access, and you're covering kind of overnight, what do I do? The therapy just has to be on hold until we're able to have a way to administer these medications to patients. Sirolimus, because it does have that 60-hour half-life, is given once a day, and the dose is based on a 24-hour trough level, with targets anywhere from even sometimes lower than 5, maybe you can even say 3, to upwards of maybe 10, just kind of depending on how the drug is being used, what other drugs it's being used in combination with. Everolimus then is given twice daily, so similar to our tacrolimus products. The levels are based on a 12-hour target trough. Side effects that we see with the mTOR inhibitors. So hyperlipidemia is a big one, specifically hypertriglyceridemia. And usually you'll see that within 6 to 8 weeks after initiating mTOR therapy if it is going to develop. Patients can also develop GI side effects, so nausea, diarrhea, gastritis. It's associated with myelosuppression, nephrotoxicity, specifically mediated through proteinuria. mTOR inhibitors are associated with poor wound healing complications, and patients may develop oral ulcers. And then there is some pulmonary toxicity associated mostly with sirolimus, is where those therapies have been seen. So you can see here the mTOR inhibitors for some patients are just not well tolerated. They may quickly kind of develop some of the mouth ulcers or some of the GI side effects. Other patients tolerate them very well. It's kind of a running back and forth of whether a patient's going to tolerate or not, and how you kind of utilize and implement the therapy of mTORs for patients. And they're used in different combinations, kind of depending on the indication as to why we put a patient on an mTOR inhibitor. And if you're wanting more information on that, we do have an mTOR CPG. When you look at all of the transplant protocols, there's one there for the various reasons why we may put a patient on mTOR: a history of malignancy, history of CMV, CKD, all different reasons. Then looking at our corticosteroids, so they have kind of the broadest mechanism of action to decrease the immune cell proliferation through inhibiting various interleukins and cytokines. Again, we give the 1 gram methylprednisolone dose perioperatively and then following the taper. Side effects of steroids, I feel like, are much more well known, so I'm going to kind of skip past that. And then very briefly, because we have had a handful of patients on this therapy, I wanted to talk about Belatacept. So Belatacept is the single agent we have that is targeted towards the signal 2, again, that binding of CD80-86 on the APC to CD28 on the T cell. Belatacept, or Nulojix, it is IV formulation only. I put the package insert dosing on here. So it started at 10 mg per kg days 1 and 5, and then weeks 2, 4, 8, and 12. And then maintenance therapy is for patients to be receiving an infusion every 4 weeks. Now, this drug is typically kind of recommended to be used in combination with Cellcept or prednisone, and there's no dose adjustments or therapeutic monitoring that has to happen with it. But the way that we more commonly have seen, or you may see Belatacept being used, is we've used it as an additional agent in patients with significant rejection burden. So there is some literature out there about using Belatacept even in combination with calcineurin inhibitors, right? So historically it was developed to substitute for the calcineurin inhibitors, but there is some data on using it in combination with calcineurin inhibitors in patients with difficult to manage or difficult to treat rejections. We have also, there is some data on using it that CD80-86 and the CD28 binding on the T cell, that actually also that CD, where this drug is targeted towards, has some action on the development of DSAs. And so in patients with persistent DSAs, persistent AMR, and or even highly sensitized pre-transplant, so they have high PRAs, there is kind of slowly case reports and case studies on using Belatacept as a way to minimize the development of DSAs. So those are kind of the reasons that we have used it. So very off-label, off-indication, but nonetheless, we have utilized it before. Adverse effects to know with Belatacept, probably the biggest thing is that patients must be sero positive for EBV, and that's because of the development of PTLD in the renal transplant literature of patients who are receiving Belatacept, most often even CNS PTLD. So it is contraindicated in a black box warning for patients who are EBV negative. There are some infusion-related reactions, but they're really quite minimal. And there's no drug interaction. So again, I just put that in there for completeness sake, because you will maybe potentially see us utilizing it. Then to kind of flip from maintenance immunosuppression to treatment of rejection. So first line for our 2R or 3R patients is steroids, usually typically 500 to 1,000 milligrams times 3 doses, followed by our taper. Second line for either more persistent or more severe cellular rejections would be to give a patient Anti-thymocyte globulin, which we already kind of spoke about. Or if a patient has antibody-mediated rejection, we have a various kind of plethora of options here, including plasmapheresis, rituximab, IVIG, Velcade, Soliris, and then tocilizumab or Actemra. So kind of wanted to quickly go through some of the AMR therapies. So rituximab is a monoclonal antibody. It's targeted against the CD20 receptors on B cells. Reasons you may see it being utilized in our patients is for desensitization on the pre-transplant side, or for AMR treatment post-transplant, or even potentially for those patients who develop PTLD. The doses there, we give a one-time dose, always given after plasmapheresis is complete. It does require pre-medications, as there are infusion-related reactions associated with the drug. The drug can only be given to those patients after we've checked Hep B, Hep C serologies. So just because the drug can cause a reactivation of those viral infections. So that's just a piece that I always check before we administer drug. IVIG you may see given for several reasons. So desensitization, again, on the pre-transplant side, AMR, infection, patients with low IgG levels. There's various dosing depending on why it is that we're using, but if we are treating AMR, let's say, we usually give a total of 2 grams per kilo. Because of volume constraints, we often split that up into 2 or 3 doses. And then again, with IVIG, there's infusion-related reactions that can occur. One important thing to kind of know in speaking about the Hep B and Hep C serologies with rituximab is I always try and order those before a patient has received any IVIG, because IVIG is pooled from thousands of people in the population. You can sometimes get a transiently false positive, some of your Hep B serologies from the IVIG, which sometimes kind of complicates our ability to dose the rituximab and sometimes often delays things even. So to just always draw those before any therapies are given. Our bortezomib, or Velcade, is a proteasome inhibitor and inhibits the activity of 26S proteasome, essentially leading to cell cycle arrest and apoptosis of our plasma cells. So reasons to give bortezomib within the confines of transplant would be desensitization, or AMR. Also, our AL amyloid patients may be receiving bortezomib or Velcade. It's given at a specified dose, 1.3 mg per meter square. It's given after plasmapheresis based on this schedule of 1, 4, 7, and 10. So kind of every 72 hours is how that falls out. We do pre-medicate, but not for any sort of infusion-related reactions. We actually give steroids prior to the drug because it actually helps to enhance the activity of the drug. Biggest side effect of Velcade for us to always be aware of is peripheral neuropathy. Obviously, infections and thrombocytopenia and neutropenia can all occur, but I think as far as side effects we worry about from a quality of life standpoint, peripheral neuropathy can develop. Eculizumab, or Soliris, is a monoclonal antibody that binds to complement protein 5, so it essentially helps to block the formation of the membrane attack complex. So reasons for this may be AMR. I put on here prevention of AMR, so there's literature in using Soliris at the time of transplant in those patients who are highly sensitized as a way to essentially try and prevent the development of AMR post-transplant. Things to know with eculizumab is it's insanely expensive, and it is a REMS restricted drug. So it requires prescriber being enrolled, patient being enrolled. It requires us to order the drug specifically for that patient. And then it is always given after plasmapheresis. So there's a lot of logistics with Soliris. I don't think it's anything any of y'all would have to ever worry about, because I or one of the other pharmacists would kind of tackle the process of all of that. I think one thing to know is that there is a risk of meningococcal infection, so we either try to vaccinate or provide chemical prophylaxis with Cipro or PenVK. Infection prophylaxis, so typically we have this 3-drug regimen: viral, bacterial, fungal, to prevent CMV, bacterial to prevent PCP, also has kind of some dual coverage in toxoplasmosis prevention. And then with fungal, we're worried about Candida and Aspergillus. So for viral, for CMV, again, and there's a lot more detail on all of this within the infection prophylaxis CPG that's available on the SharePoint. But to prevent against CMV, we often use Valcyte, valganciclovir, 3 to 6 months based on a patient's risk. When we're looking at bacterial or PCP prophylaxis, Bactrim is our preferred agent, and they're on that for a full year. We also look at a patient's toxoplasmosis risk, so looking at recipient and donor status. If the patient is toxoplasmosis IgG positive, and or there's a mismatch where the donor is negative and the donor is positive and the recipient is negative, Bactrim is absolutely our preferred, just because of its activity also to inhibit toxoplasmosis. Our backup then, kind of based on whether we're just looking at prophylaxis of PCP versus PCP and toxoplasmosis. If it's PCP and toxoplasmosis, next preferred would be atovaquone or Mepron, because it's the only other agent listed there that also helps prevent against toxo. Otherwise, other PCP prevention options are dapsone, atovaquone, or pentam inhalations. And then for our fungal prevention, voriconazole, talked about that a little bit earlier with its interactions with Prograf, which can complicate things logistically as far as adjusting tacrolimus levels. And so we try not to kind of start and stop that too frequently. But typically 3 months, if a patient doesn't tolerate voriconazole, another option is itraconazole. Most reasons patients don't tolerate voriconazole would be any sort of LFT elevation from the azole antifungal, or patients can develop visual hallucinations from the drug, and is usually an indication to stop therapy completely. Our typical infection prophylaxis is for all of our patients immediately post-transplant, kind of based on those durations specified there. And then also if they ever receive Anti-thymocyte, rituximab, bortezomib, it would also include there if they were to receive Soliris for treatment of a rejection, then they would be put back on all 3 agents for an additional 3 months. If a patient is treated for a 2R or greater, so a 2R or 3R, 3 or more times within 3 months. It can be a little complicated to remember that, but so essentially if a patient's getting bolus dose steroids 3 or more times within 3 months, we kind of deem that as enough steroid exposure, because if you think about it, that's essentially getting up to 9 grams of steroids within 3 months, plus their maintenance and tapered doses, that is also an indication to resume 3-drug prophylaxis. Drug interactions, kind of spoke a little bit about this, but really the things we got to keep an eye on are those things that will increase our CNI levels. So our azole antifungals, non-dihydropyridine, calcium channel blockers, the macrolide antibiotics, specifically erythromycin and clarithromycin, protease inhibitors for patients who may be on it for concomitant HIV or other hepatitis. And then drugs that can reduce the level. I would say the biggest thing that's come up here is patients who get started on phenytoin or phenobarbital in the sense of any drugs that kind of have a byproduct of phenobarbital. So those can induce 3A4 and then thus drop your level of your CNIs. The most potent of that we do have to worry about is patients who ever are started on rifampin. I don't know that I've necessarily seen any heart transplant patients require rifampin, but have seen it in other organ types. And the induction that rifampin does on 3A4 makes it that oftentimes Prograf doses have to be 5 to 6 times what they were prior to rifampin, which makes it nearly impossible actually to monitor. And usually we're looking for an alternative to rifampin as a way to be able to handle and dose our maintenance immunosuppression. And then obviously anything that's going to have additive nephrotoxicity. With the mTOR inhibitors, again, metabolized by 3A4, so kind of same things that could increase or decrease levels. And then other interactions would be those things that have additive bone marrow suppression. Same with mycophenolate. There is some thought that antacids can reduce drug levels of mycophenolate. I don't know that I necessarily completely buy it, but cholestyramine, not something many patients are on anymore, but it will bind up mycophenolate. And then kind of speaking about binding, to deviate a little bit from this, the new potassium lowering agents, so Belatacept and Lokelma, both of those drugs will bind pretty much any drug, but especially mycophenolate and our anti-rejection drugs. So those therapies must be separated from immunosuppression by at least 2 hours. I usually educate patients to separate by 3 to 4 hours. And then should a patient be on azathioprine, I think kind of the biggest thing to always be concerned about is if they're on concomitant allopurinol or sulfasalazine. And that is everything that I have for y'all. What questions do you have that I can answer?
A question did come in through the chat if you want to look at it, Jim.
Yeah, let me pull it up. Is it okay to cut the CellCept tablet? No, actually, if a patient requires 250 milligrams, it's kind of a nuisance, but if they have to be switched to the capsule. So here in-house, obviously it's easy enough, you just switch them to the capsule, but if a patient is outpatient, they really shouldn't cut that CellCept. Even though it is not a delayed release product, cutting the CellCept will most likely lead to more nausea and gastritis for patients. I know I've met, especially for kind of the fellows and or residents listening in, I know I've met a lot of you, but if anyone ever has any questions, you know to just reach out to me or ask one of the attendings for my cell phone number and you can call. Happy to help.
Hey Jill, this is David. Just for curiosity, is this pretty much the same presentation you get to the transplant nurses done for in ICUs?
It's very similar. We put a little bit more stuff in there about nursing administration as far as kind of lines and infusion times and timing of pre-meds, but yeah, it's very similar, yeah.
Jill,
Yeah.
just for curiosity, what are your thoughts on immunosuppression and COVID with the current pandemic? What are some of the things that we are doing now as a team?
Vanessa, you were cutting up a little bit, but I think was your question on kind of immunosuppression in the time of COVID?
Yes, that's correct, in the COVID positive patient.
Yeah, so I think typically across all organ types, what most are doing is to either stop or reduce mycophenolate, assuming a patient's on mycophenolate. I think that's been most people's first approach. And then really kind of approaching the CNI from a standpoint of like, what is the risk for the patient, right? If a patient's only a month post-transplant, we're obviously going to want to be a little bit more aggressive with where their CNI level is versus someone who's years post-transplant and has developed COVID. So I think there's kind of different approaches there. And then, I mean, it's an interesting process because we don't think of it necessarily exactly the same way as we do other viral infections, right? Like CMV. CMV is a lot clearer that we need to kind of minimize immunosuppression. But because of the actual cytokine response associated with COVID, I think it warrants a different approach and a different thinking about it, that it doesn't necessarily mean we should withdraw all immunosuppression or back off too much. We have to kind of look at everything that's happening with the patient. So yeah, but usually at least I think a general accepted approach has been to reduce or stop mycophenolate.
How do we reach the overnight pharmacist if we're on call?
So great question. So we have ICU coverage of clinical coverage in our ICUs. And right now that position is kind of, there's 2 people who are always in that position, and then we have a bunch of PRN staff that is helping out because overnights have been so busy the last couple of months. But what I usually recommend for overnight especially is if it's something specific, like I'm trying to figure out how to put in a patient's home tacrolimus or something, to put it in as a consult. Just put in a pharmacy consult, dose medication, and kind of you can put in your contact number there. The 2, I'm not actually certain if the 2 overnight pharmacists, if they like have one Cisco phone number that they share and pass off amongst one another. But typically they do work out of the Walter Tower 10 pharmacy area as a way to just kind of know where to reach. When in doubt, you can always call Central Pharmacy and they can direct you to who it is. But really, I always say overnight, I think the easiest thing to do is to put in a pharmacy consult. They see those relatively quickly and are able to kind of reach out to you, or if it's something like help me convert a patient's tacrolimus, they're able to take care of it quickly for you.
Hey Jill, just out of curiosity, when you brought up the retux, a couple things went out. When we get these patients that gets retuxed and that they're, if it's been like in 2 or 3 months, should we go ahead and get them revaccinated for like influenza and that there?
If they're, I mean, depending on where they are within the flu season, let's say. So the problem with any of those more potent drugs, especially those that are targeting B cells or plasma cells, is the likelihood of a vaccination, them not mounting an appropriate response. And so let's say they received rituximab in July, then obviously within a couple months, they should really be getting their flu vaccine anyway. Let's say they received their flu vaccine in September and then we gave them Ritux in October. I think it's worthwhile to, kind of 3 months from that, again in the spring, you can always, if their
Get 'em
insurance
again?
lets them, to get them again. But there's nothing really clear on that. I think though with the flu vaccine is kind of maybe the most straightforward, but with all the plethora of every other vaccine out there, it's not as clear. If they were like in the middle of, let's say they're getting their Hep B series vaccines, and kind of in the middle of it, we end up treating them for a rejection. What I usually say there is like complete out the series, and then that's a patient that it may be worthwhile to actually check their titers at the end of the series to see if they actually mounted a response or not, which they may or may not have done for Tux or not, just in the setting of maintenance immunosuppression, they may not always mount a response.
Thank you.
Hey, Jill, I have a question. You said that when patients are treated with 2R 3 months, like repeated 2R, so you put them on all 3 agents, and then is it for 3 months, or what's the time? How long do you treat them?
So if they're treated for cellular 3 times or more within 3 months, you put them back on all 3 agents for 3 months.
And that's regardless of their serology.
Unless if they were CMV negative, and they only have received steroids, I think you're fine to just put them on acyclovir or valacyclovir, so acyclovir or Valtrex. If a patient's CMV, so they're their lowest risk, negative, post-transplant, we also would only have them on acyclovir or valacyclovir. But even if they're negative, if they got rituximab or thymo or a essentially more potent depleting therapy, they would get Valcyte. So even though their risk is low, getting more potent therapies kind of knocks them up we approach it as if they're an immediate risk instead. Well, that's all I got.